to the language they speak to the doctors to clean the diagnosis. Next. In 26 November 2016, the world celebrated Anti-Obesity Day. We know that, next please, this obesity is the #1 killer in today's perception. Next. Alopecia that comes in, hirsutism that flows into the obesity. Next. We will all see that acne is a very pertinent symptom. Next. Discoloration, or what they call it, acanthosis nigrans, is also very prominent. Next. And finally, the fat around the hips, what we call it, a central obesity. So this is a clinical spectrum that we are trying to look into in today's discussion, and whether we can strike with something for one and all. Next, please. We all know this. I'm not going to tackle it one by one, but if you can tackle obesity, I think everything that we are seeing around obesity will be taken care of. Next. So the PCOS, which has got so intricately related with the obesity and also the insulin resistance, are what we will discuss today. Look at this particular so clear statement. Everyone is getting pregnant and having babies, and whereas a PCOS woman is just sitting idle and making ovarian cysts. That is what every patient comes to us and say, I'm having a lot of cysts in my ovaries. Next. The consequences of adiposity is rampant in every system of the body. That what we all know, from reproductive disorders to the menstrual disorders, from infertility and up to the sleep apnea, we still now have a dormant symptom, and we need to strike in this particular sleep apnea to detect more diagnosis of this particular condition. Next. So the content that we'll take up today is adiposity and the consequences on fertility, adiposity and PCOS, lifestyle interventions like diet, exercise, and some drugs, not overall, because that itself is a huge chapter in it. Effect of lifestyle on PCOS, which doesn't cost us anything but gives us everything back. And finally, few take-home slides for everyone to recapitulate your day-to-day practice. Next. So we'll discuss something on adiposity and its consequences on fertility. Next. What exactly the adiposity does on fertility? We already know the basics of the physiology, that a follicle starts to grow from the antral follicle, the dominant follicle takes them, then finally the follicle matures. But in PCOS, with adiposity, there is follicular arrest. Next. This particular arrest is limited to around 8 to 10 millimeter size, and that is where the hormone production of this particular follicles is restricted to the more of an androgen type, and that remains the key manifestation of adiposity with PCOS. Next. We also have to understand the body weight has an inverted effect on the reproduction. Too thin and too obese are the two detrimental arms. What we want is an optimized way. That's where it will be easier for every one of us to tackle fertility. We also have to understand that BMI has been the standard form of measurement of physical health, but today BMI has not been considered the ideal way. We are yet to find out the ideal measurement, but waist-hip ratio or even a simple waist circumference gives us a lot of information about the adiposity of that particular woman. So the evidence in reproductive literature is based totally on BMI, which is not the exact criteria of defining obesity or adiposity. Next. So what we have to do is we have to take a tape in our clinics and take a measurement around the hip, around the umbilicus. That ratio becomes the most important waist-hip ratio, and we can define adiposity. And in terms of PCOS treatment, if we can get down that to the normalcy, I think a lot of our treatment costs will come down without spending anything. So the obesity and reproduction has got a lot of ill effects, starting from menstruation, infertility, miscarriage, glucose intolerance, and so on and so forth. Even when these patients get pregnant, we'll have to appreciate that they have a high tendency to develop hypertensive disorder for pregnancy, diabetes mellitus, even difficulty in C-section, and also they have an increased tendency of developing Down syndrome. Next. So we have to understand the mechanism, and to understand the mechanism, we'll have to go little more deeper into the pathophysiology, which I'll just sum up in 2 slides next, because there is excessive production of androgens to estrogen, and also there's overproduction of estrogen from estradiol or even androstenediol. Extremely active endocrine organ secreting cytokines, growth factors, and even vasoactive factors collectively termed as adipokines, which represent the adipobiology and function in a both autocrine and a paracrine manner in this group of adipose people. So this adipose tissue is the central part where we have to strike. Next, please. So the main organ that we have to deal with is the adipose tissue. And today we consider it as the largest endocrine organ in the human being, because it is involved with the metabolism of estrogens to 2-hydroxyestrogen or 17-hydroxyestrogen. It also is the storage of the steroid hormones, and also the effect of adiposity on insulin secretion on the pancreas because of insulin resistance comes in. A word about the leptin, because we have to understand what exactly this hormone is, though we are not clearly defined how leptin acts in tackling adiposity, but today leptin plays a central role in gaining adiposity. Next. Appetite regulation may be disturbed in this group of adipose people, but another hormone in the name of renin is also coming, which is derived in the gut. So all these new hormones we have to get tuned to, and everyone interact with the other to create an environment of increasing adiposity and contribute more difficulty in the management of the PCOS. Next, please. WHO has recognized obesity as a disease way back in 1948. We all know that this is how detrimental it could be. What we have been trying to do is we have been trying to focus more on the body mass index, but body mass is only a surrogate for the body fatness. So we need to change our parameter to the waist-hip ratio, or even for far more better parameters like peripheral fat distribution. True adiposity can be measured by different measurements like DEXA or even bioimpedance. We need to get used to this, not only with the BMI that we have been doing so far. Next. Individuals classified as a normal body weight by BMI axis, it's also very detrimental, because we tend to have a very false security that our BMI is within 24 or within 22, because these standards are all based from the Western data. So for Indian classification, the BMI has to be below 20 to be perfect normal in today's scenario. Next, please. So this is a very complex diagram where we have to understand that how the fatty tissue develops, and the mesenchyme of the skin cells are responsible, because today we know the white fat cells, the beige fat cells, even the brown cells, they all have an intricate relation to one another, and they contribute a huge to the endocrine behavior of that particular person. Next. This endocrinology is also has to be understood in depth, because once they are acquired in utero, they need to carry on and they behave in a different way. And we have to understand that in utero is the most important part to look into to prevent this adiposity, where we OBGYN also has a tremendous role of passing on information to the pregnant woman, because if you are to treat adiposity, it has to be tackled in utero only. Next slide, please. So, next slide, please. We have to understand that there is a balance between a healthy adipose tissue and chronic inflammatory tissue, adipose tissue that we tackle. And that is where the cytokines, basically interleukin 4, interleukin 10, and interleukin 13 comes in. Because the obesity is characterized by the polarization of macrophages towards the pro-inflammatory M1 phenotype, as well as with the shift from anti-inflammatory thymus 2 to the trade CD4 plus cells from pro-inflammatory to thymus 1 and thymus 17 CD4 plus cells. Once this shift takes place, it becomes very difficult to tackle, and that is why this chronic inflammation with adiposity is very difficult to get it down to normal. And this is what we need to pass on to our patients, because some sort of persistent effort has to be given. Adiposity cannot be conquered in a day's time, in a week's time, or even in a month's time. The persistent effort is required. And this mechanism, if we can explain to our patient in simple terms, I think the job of the clinician is being done. Next. So, adverse effect of weight on reproductive performance is known to everybody. Different studies have proved this. So the raised BMI is associated with higher incidence of infertility is well known to everyone. But different studies have got different loopholes. What we have to understand, an obese patient without a genetic influence can become fertile easily, whereas with a genetic influence, they will be finding it difficult to prove their fertility. And that is where every treatment has to vary from their family history, from their genetic profile of the particular patient, and we also have to understand it inside out. Next, please. A child which is obese has got a tendency to carry on that obesity to the adulthood and then to the post-adulthood period also. So the adverse effect of weight on reproductive systems are very well known. What we have discussed at the initial slide is will be rampant, and we need to tackle the central part of all the different disease process, that is obesity. Next. Today, what we'll try to do is, we'll try to see how can we get the best response to treatment. Increased BMI, we have to stick to the higher doses of stimulation, higher requirements of gonadotropin, and high weight-to ratio, which is the central reference point for central obesity, is associated with a very low conception rate. So if we are to strike goal in a fertility treatment, I think the best way is to spend no money and ask the particular patient and a couple or the woman concerned or the girl concerned for their treatment that you need to modify your body shape without spending anything, and that is where you will get the best result and a permanent result for the next years to come. So the reproductive response to the diet and the infertility treatment are so closely related to the central body fat. If you look into the general physique of a woman around 40, they try to put in more fat around the central region. And that is where the fertility also goes down. So we can just reciprocate this concept to the younger women who are eager to have fertility. A woman with more central fat will have difficulty. This is well known to everyone. So to make them understand, we can give an example to the lady around the perimenopausal woman who tends to put in more fat in the central region, because that is the natural defense against fertility. Next slide, please. What we also have to understand that women with central fat have high levels of luteinizing hormone, androstenedione, sterone, high level of insulin, triglycerides, all bad parts of the hormone that we don't like to have, because they are central to the cardiovascular system illness, they are central to the endocrine disorders, and they are central to the OBGYN departments as well. Next, please. So, if we are to strike this in the journey of PCOS, we have to understand that we need to rope in too many people, too many disciplines for perfect cure. We are in the forefront as a clinician. We need to enroll dietitian. We need to enroll 3 of the exercise specialists to modify exercises as per the requirement. And the strongest of the team members should be the counselor. I think a clinician can be a very good counselor provided he or she has time, because the patient relies more on a clinician, and as we pass on, they tend to have a belief that the counselor may not give them the right knowledge. So as a basic primary clinician, our role is to give due importance and stress to the other members of this team. Make the patient understand that the dietitian has got a strong role to play. Exercise specialists will also have to come in a bigger way, and the counselor will keep on counseling you repeatedly so that, next please, we have their effect permanently. I'll just try to quote what Bruce Lee said. Knowing is not enough, we must apply, because we all clinicians know everything. Willing is not enough, we must do. See, getting our knowledge transferred from the clinician to the patient's perspective is very important. And that is where a good clinician is different from an ordinary clinician. If you have a good counselor, if you have a good dietitian, if you have a good exercise specialist, you score as a primary physician. So making a prescription is important, but prescription along with this additional benefits are also important in your day-to-day practice. Next, please. We need to think on what lifestyle management in PCOS can do. We have to understand that insulin resistance has to go down. We all understand that insulin resistance is never hidden criteria in PCOS diagnosis, though 60 to 70% of the PCOS patients are insulin resistant. But if you improve the insulin resistance, the final outcome is improved. That is where the mechanism comes in, and we have to stress the importance of insulin resistance. We have to improve the mechanical metabolic features, improve reproductive function. The general image of the person gets improved, and thereby her mood becomes elevated. So overall, lifestyle management is central to all this. I believe prescribing a drug is important because being a primary physician, people expect from us, but putting a lot of weightage on the lifestyle management should be the primary role of every physician. Next, please. Because this doesn't cost us anything. Weight reduction includes a combination of caloric restriction, increased physical activity, and also some behavioral modification. And these words can come from a counselor. But if these words come from primary physician, I repeatedly speak this, from a primary physician, the patient or the particular person concerned will give it more importance. And we as a primary care provider need to realize this and stress upon our patients the importance of lifestyle modification in every PCOS patient, be it a lean PCOS or be it an obese standard PCOS. Next, please. What is the effect of weight loss? We know our body contains a lot of water. So if we want to maintain that amount of weight loss, we need to hydrate our body as well. And everyone has to understand that the weight is proportionate to the fat. If the person doesn't go to the gym on a regular basis, I think what she gains is only the fat adipose tissue. So that adipose tissue has to go down to normalize her hormonal milieu. So if we can decrease the 5% of the standard body weight she is carrying at the time of producing her symptoms, her insulin resistance will go down. Her circulating androgens will go down. So this will result in spontaneous correction of her cycles. And once the correct cycle is being corrected, her mood will get elevated. She will get more energy to rope in, more strength to do more exercises, and thereby she will return to her normalcy without doing a lot of spending on treating her illness. Next, please. So today, I will be stressing repeatedly on the benefit of lifestyle disorders because this has been my central theme for looking at this PCOS patient, even at the peripheral centers as well. Yes, people do expect a lot of medicine from us, but giving time, making them understand the benefits attained from lifestyle modification are central because they are permanent to contribute to the better health of the woman as a whole, and not only tackling the symptoms for which she has come to the primary physician. So if you are looking to the cardiovascular risk factor, they also get aggravated once we take this lifestyle into consideration. Next, please. Today, they have become an important part of our day-to-day life. Our younger generations today are more into the gyms They are more into the Zumbas. They are more into the yogas, aerobics. See, everything is important. But when they come in front of us to a clinician, you need to spend little time on the type of exercise the girl is interested. If she is interested in swimming, if she is interested in doing gymnastics, we should promote that particular interest in her so that she continues to enjoy her exercise and in turn get benefit of her illness or her presenting symptoms. That is what we should stress upon. Every exercise contributes a bit to it, and it doesn't mean that she has to go for walking every day. She has to go for gym every day. So she can enjoy her day-to-day activities, at the same time burn her calories and restrict her calorie intake, and finally contribute to the better result. Next, please. So, target population that we should always address is the mother. Why I say mother? The treatment starts in utero. The concept of getting a healthy baby in utero is central to the PCOS management. So, a mother should be given this importance. The baby in utero has its genetic influence for next 3 generations. If you speak the simple line, the mother will get little more important and say, yes, I'm going to produce a healthy baby for next 3 generations that are going to come in. So she has to rope in with healthy eating habits. She has to exercise a little bit during pregnancy as long as she is not tired. Next group of people is the school learning process. So this is where the motivation becomes more important. If we allow the students only to sit down and learn, I think we are losing out. And those are the moments where we need to rectify and give suggestion to the educational system that teenagers need to be active during learning phase as well. Next. More so, we can also rope in the target population who comes to us. We can fix up a group of a particular day in a week and ask them to come in groups so that the doctor concerned or the counselor concerned or the dietitian comes together, address them one by one. And they will also feel how important they are being given by all the group of people, care provider. And the result is really fabulous. So, what is the lifestyle modification that have been stressing so long? They have to exercise initially in a moderate way, and that moderate is more than 30 minutes per day. Some sort of dietary modifications will also have to come in, because if they do not restrict their calories, simply doing exercise will not give them a lot of benefit. The fat intake, which gives us lots of calories, has to go down less than 30% of the daily allowance. They have to decrease the saturated fat and trans fat and have to give more importance to the monosaturated fat. The glycemic load has to be lowered. For weight loss, they have to establish an energy deficit of 500 to 1000 calories per day. And this is really possible if they are being roped in with a dietitian who is so tuned to reduce the body weight in type of diet, because a dietitian can give you the perfect one. We have been hearing about a different webinars given by a dietitian, Silpa from Mumbai. She is giving so motivated dietary preparation to their clients. I think everyone will get motivated to reduce their calorie intake and maintain their healthy status in a perfect way. So ultimately, there'll be reduction in the psychosocial stress. And once the ladies who smoke, especially in a rural area, they smoke bidis, they should be discouraged. Alcohol consumption has come into our children in a huge way. We should discourage that. Caffeine consumption should be discouraged. And more we should rope in is a group interaction and group discussions and group promotion of different activities so that they find more energy to work together, learn together, and maintain it together, because it is togetherness that holds everyone in the day-to-day life. Next, please. So, diet for PCOS is very important. What to eat, what to avoid is central in lifestyle modification. I know this is not a cup of tea of a clinician where we need to give you a perfect way, but I'll try to give you some hints. Try to get in a dietitian of your own who can guide you and give you the diet that you really want for your subclass of people. Next. So every diet is important. Every diet has to be perfect for an individual. We cannot have a standard diet for every PCOS patient because it has to be proportionate to the disease or symptoms she is producing. On a standard way, what we can say is 30% fat, 50% protein, 15% protein, and 55% carbohydrate. So this is what we need to get down to even 20% if she is more obese. Altering the type of carbohydrate to produce low glycemic response is important because the glycemic index is central to the classification of different carb foods. So as a clinician, if you can guide them that if you're taking a carbs with very high glycemic index, I think that should be discouraged for our group of patients. So carbs are important for an average day-to-day calorie requirement, but carbs with a low glycemic index is what will be more preferable. And if you can add to this, I think we will become a great clinician in this particular aspect. So dietary composition is not the key, provided calorie intake is reduced substantially. So we need to keep a balance of everything. Next, please. Pulses should be roped in because they have to give requisite protein supplement which gives us a constant energy for a longer duration. Our satiety center will not be stimulated if you're taking good amount of protein so that we will not feel hungry so soon. If we are to rope in certain sensitizing agents like metformin, inositols, yes, we can always do that, but my personal preference would always be without taking help of medication. Motivating a particular patient with proper information is the central to my way of practicing PCOS lifestyle, because a proper information given to a right patient can really transform her life and get her to the normal waist-hip ratio and bring her from the PCOS to a normal adult woman. That is what I have been able to do it in my 36 years of practice. Next, please. Yes, if we can do that in prescription, it is good. So to cut down on calories, especially more so in the evening, is important. From the evening onwards, our activity goes down. So if we are taking a very heavy evening snacks or a very heavy dinner, it will be difficult for us to get the best result. Why I say this? The calorie that you have consumed must be utilized immediately. So if you're working in the evening hours, if you're going to gym, if you're going for a walk, going for a cycling, going for a dancing in the evening session, I think cutting down will also help you because your energy spent will be on the positive side and your calorie intake will be on the negative side. So the most health professionals recommend creating a calorie deficit of around 3,500 to 7,000 per week for healthy and successful weight loss. This is what every clinician has to remember. And this is not a small amount of calories. Next, please. So the point number 2, we must all favor monounsaturated fats because they are good quality of fat and they will help in acquiring a better result because the polyunsaturated fats will produce a lot of side effects and ultimately the damage that will be done to the adipose tissue. They will produce more chronic inflammatory adipose tissues and ultimately we'll have a difficulty in getting them down to the normal. Next, please. So our next point is National Institute of Health Clinical Guidelines for long-term treatment of overweight and obesity, because these patients need a long plan. A short-term plan is never sustainable. So you have to give them this idea. If you're coming that you're going to get down your weight in 7 days, like crash diet, it is no good. It is detrimental for your general day-to-day life. So a sensible diet and sensible eating habits for a long-term, effective physical activity program which is sustainable for a long term has to be effective for that particular woman. Behavior modification, reduction of stress, increased well-beingness is also central. A combination of dietary and behavioral therapy, which will increase their activity, which will increase their calorie expenditure and reduce their calorie input, are important. Social support by everyone, not only the physician, by every member of the family, every member of the treatment team, even the partners and also the peers are central, because you spend more time with them. So everyone where you are being surrounded must be stimulated continuously with the same information, so that she is maintaining a perfect mood to continue her effort to reduce her weight. Next, please. The crash diet is one that we should never do. If you're looking into the weighty method, see, this is a pretty old, I should say, yes. This is 2013, but still it has a lot of relevance. If you're looking into the world ranking, we come at 176. But today at 2020, we are much above, and we are into the top 50 growing fatty populations, increasing fatty populations in the country. So if you are looking into this information and trying to console ourselves that India is a country of undernutrition, obesity cannot come in, I think we are totally wrong. Even in the rural areas where the dietary habit of taking more high glycemic index carbs have got more obesity. So information percolation from the physician to the every attendees of your clinic, even if they are not coming for your gynecological clinic, if you are putting a leaflet for information how to take care of your health, will play an important role, and we can come out and go down to 176, and that is what my intention of preparing this talk to every one of you. Next, please. What I'm trying to do here is giving due importance to our day-to-day habits. I think if you're looking into this particular diagram, you can all make out what an important impression this particular slide can make to all of you. And if you have appreciated, I'll be happy. Please put it into practice. Please recommend this to your every PCOS patient who need weight reduction, and I'm sure you will get the best possible result at the earliest possible time. And I'm also sure that patient will glue down to you with a better health for next few generations. Next, please. Diet is so important. Since 1990 and since 2001, when the flat TVs have started coming to the market, the scenario have changed. I just want to reverse this. We want more thin people in a society, standard people. I don't mean even thin people. We want more standard people with normal parameters in the society, not the obesity, because it takes up a huge amount of health budget, huge amount of energy for every clinician, because this is preventable. Next. These few diagrams will really make an impact to you. Next, please. So, what I try to do in my practice is, if a girl comes, I tell them that in the next ceremonial function, I'm going to present you a gene of 28 size, because at present, his requirement is 36 size. So you have to get it motivated. You don't have to really present them, but passing on the information is so important to them. They understand, because everybody wants to look good, and we Indians spend so much of money in looking good. We should motivate everyone, take advantage of this and give them the information. I'm sure everyone will spend that extra calorie, take more balanced diet, and correct their illness too, and at the same time look good for day-to-day habits. So this is important, because the reduction of weight will give you reduction in androgen and help in increasing fertility and regularizing her symptoms. Calorie restriction with a subsequent of 5% low in body weight will help in gaining their normalcy. This will, because there will be change in insulin level, there will be change in insulin growth factors, sex hormone binding globulin value, and also she will normalize her maturation, which is their primary important function of coming to a clinician. They will improve their clinical as well as biochemical parameters, because we as a clinician look to improve both together, because we understand what lies behind their obesity. Next, please. So surgically induced weight loss has become more popular today. The people today are going more into the surgical modality of treatment. But remember, if you are doing this, it's okay for a time being. But if you're doing into the obstetrical outcome, this is where we are on the losing side. So it is better to put them on a natural way of losing weight than to put them on a surgical way, because surgical way will pave a way for a natural way, but ultimately their obstetrical outcome will be compromised to a certain extent. Next. So weight loss and exercise are very important. Slow and sustained weight loss is more preferable, because they are going to give you a better way of sustaining the effect of the benefit for a longer time. No massive calorie reduction is recommended, because once you stop that, again the things will come back to you. So unique group approach remains ideal for our group of people. Alteration of lifestyle, particularly weight, will lead to a short, medium, and long-term benefit, and more so a permanent benefit for her health, by which she will get all the benefits of the side effects of obesity. And this is what we have to stress to them repeatedly. Hammering them to their brains on every visit will be our central point of sustaining to the benefit of PCOS. Next. I'm not going to talk more about the drugs, because that is where we have been getting a lot of webinars on this. But I try to focus more on the lifestyle approach, because this remains central for everyone to do it. And if we can recommend this as a routine basis to everyone, I know everyone does it, but putting a science behind doing this will be more from today. And I think you are going to get a better result in this PCOS overweight as well. So the fertility fitness program will have to be roped in. You need to pass on that information about the role of weight and body composition in reproductive disorders. Agreement to seek lifestyle changes for at least 6 months prior to becoming pregnant or expecting a good positive response for fertility. Group meeting with partners to explain the course of their treatment and course of their counseling session, course of their exercise, and so on and so forth. Spending 2 to 2.5 hours with the woman concerned is very important, because they have to understand it on a regular basis. Aerobic exercises like walking for 1 hour a day will help us to regain their cardiovascular health. Put in practice for the next 6 months, and I'm sure we are going to do a great good for this woman overall. Next. I'm going to give you some suggestions henceforth, which will be central to your day-to-day. Obesity and sedentary lifestyle in PCOS is associated with anovulation and failure of infertility treatment. We have understood, we have said this, the basic pathology is failure of acquiring dominance. So the follicle gets arrested, there will be anovulation, there will be hyperandrogenism as a whole, and the result of fertility are far and remote. So this has to be countered by primarily lifestyle modification, and exercise and diets play a central to this. So what sort of modification? Weight loss has to be precise, it has to be individualized. So a specialist like exercise specialist has to be roped in. So amount of exercise she can do to get her weight to the optimization is very important. Because if she enters pregnancy in an overweight stage, she has all the complications like from miscarriage to diabetes, to the hypertension, even during cesarean section, she will end up with a lot of problems. And we all know even preterm labor and IUD are a part of this obesity program. Next, please. So lifestyle management in PCOS is the best way. We all have to also understand that there is no best diet and best exercise regime for one individual. One that is good for one may not be ideal for the other. So individualization is the key, but as a care provider, passing on the central importance of diet into their day-to-day habit will be the most important role. If we pass on the caloric restriction, increase physical activity in every visit, push them in every meeting that we meet, every counselor in the sessions, every exercise specialist will put it in, they will get the best benefit. How much we are asking for? At least minimum of 5% of the body weight. And we all have proved this. Getting more is the best, but to get something at least in the 5% of the body weight will have to go down finally. Next, please. I must give you a final take-home slide. If you have not remembered anything in my presentation, please try to remember this slide, and I'm sure you will have learned everything that I have spoken for last 40 minutes. What is that? Kickstart your metabolism by increasing your activity. Your diet must be protein rich, as I said, because if it is protein rich, your satiety center will remain sustained. You will not get hungry sooner. This white curve, that means all white curves will have a high glycemic index. You have to count your nutrition every day in every meal, but don't count on calories. Preferably no alcohol. Interval training is more important. You should not skip the meals because they are more detrimental in sustaining the calories for the day. Small and frequent meals are more advocated for one and all. Eat fat to lose fat. Eat whole grains. They are more beneficial. You will get the added benefit of the vitamins and proteins together. Drink plenty of water to maintain normal body composition. Run to get more vigor and better health. Get enough sleep. 7 to 8 hours sleep is preferable if you can, but minimum should be 6 hours for sustaining a good health. And most importantly, if we have acquired everything, I'm sure you can keep relaxed, you can keep calm. I'm sure your patients are bound to get the best benefit, and you are the winner at the end of the day because your patients will come to you with a positive result. Thank you so much, every one of you, those who have joined in. Thank you, Sil, for giving me an opportunity to be with you on this difficult time. Why I say difficult time? COVID has been a difficult time for every one of us. We have cut down on our work every day, but more importantly, with the cyclone that has hit the West Bengal and to some part of the Orissa and also the Northeast, we are finding it tough because the webinars will be very difficult to telecast from this region because of poor internet connectivity. But today, hopefully, I'm hopeful that many of you remain connected, and thank you for joining for this webinar, which has a lot of information on lifestyle. And this is what I say is central to the all PCOS management. It doesn't have any monetary expenditure, but on the other hand, you are getting the maximum benefit for the management of not only PCOS, for a long-term benefit of a better health. Thank you, Sil, and thank you everyone, those who have joined in, and I'm ready for your question and answers.
Sir, good evening. This is Dr. Kiran from Shield Healthcare. Sir, thank you for a very, very wonderful and extremely informative session. All the audience found it enriching, especially with a lot of practical. I think you emphasized that obesity is now a pandemic, and it is central to all the diseases, whether it is CVS or whether it is diabetes. Thank you, sir. Sir, I'll read a few questions to you which are coming up.
Yeah, just 1 minute. I didn't use the word pandemic because people today are becoming very much uh, motivated the word pandemic because the COVID has become pandemic. So if you are using the word pandemic, I think they will all get demotivated again. So I'm trying to avoid the word pandemic, but yes, in real sense, it is. It is right. Yes, please.
Thank you, sir. Sir, the first question is from Dr. Nivedita Datta. So, ma'am is asking, in case of a lean PCO patient, sir,
Yeah.
what lifestyle modification is recommended, in your opinion?
Yes, that is what I said. The women tend to have more fatty tissue in comparison to the man. Even in lean PCOS, the visceral fat component is much more than what we see from external surface. The same principle of 5% reduction of the even in lean PCO will give them a better stimulation protocol, better follicular growth rate, and better fertilization rate. And this has been proven in well-controlled studies across the globe. So, a lean PCOS, yes, it might look odd to the person concerned, but studies and even clinically I have found reduction of even 4 kilos in a lean PCOS give them a much better outcome as far as fertility is concerned.
Thank you, sir. Sir, you mentioned about eat fat to cut fat. So Dr. Bibaja wants to know what type of fat do you recommend generally?
By that I mean we are trying to eat more type of polyunsaturated fats. If you are trying to reduce this, then you have to take more of the monounsaturated fat because this is also fat is requirement for our day-to-day life. We have to appreciate that we cannot take diet with only bland meals. Fats is a very important component of our body and it is vital to many of the functioning tissues of the body as well. So you have to change from the polyunsaturated fat to monounsaturated fat because that is why I said eat fat to reduce fat, and that is what I mean in real sense.
Thank you, sir. Thank you so much. So the next question is from Dr. Aditi. She wants to know if some information can be given on specific types of food to be eaten in PCOS. It would be helpful.
That is what I said. There is no standard and a based regime for one and all. But what if you want to give, if you as a clinician, if you want to remember, the best thing would be, yes, you cannot ask the patient to cut totally on carbs. This is not possible. But definitely you have to insist on reducing carbs with high glycemic index. Especially if the patient is allowed to take fruit, yeah, they should take it whole fruit. They should not take only the juice. Similarly, the rice that we in the northeastern part and the people in around the southern belt from Tamil Nadu take, they have a high glycemic index. So if you are to modify these rice eaters with what we call it, we in our local language have a different terminology for this, but today we have around brown rice, black rice, or a special type of rice which doesn't have high glycemic index. They are to be recommended for especially in insulin resistant patients. What I do is, if I have to enroll drug, because normally I try a strict regime of diet for them for 6 months, and in this 6 months I expect a reduction of around 1 to 2 kgs only, because it is not easy to get the weight down only with diet. But if you are allowing a diet which will help them to put in more weight during this regime of exercise, I think we are losing out all the motivation factors. Ask them to take a lot of nuts, lot of grams, lot of proteins, so that your satiety center is not being stimulated, and ask them to remain withdrawn from raw sweeteners, sweets, and you'll gain a lot from them. Thank you. I hope I should be making some clearance to them.
Thank you, sir. Thank you so much, sir. Sir, you spoke a lot about lifestyle modification. So I just want to know your opinion on myoinositol and D-chironositol. Would they be helpful in addition to the lifestyle modification?
Yes. I think nothing, once the shield is in, we cannot really think of anything beyond inositols. See, people today are so much tuned to Google. If you are prescribing a drug, they will go to Google, they will say this drug has so much of side effects. Now, what I have been doing is, I'll tell you, inositol is a vitamin that you have to stress to your patient. And once they hear the word vitamin and they find the resemblance in Google that this is a vitamin, they will never hesitate to take this. But to get them to the best possible benefit, we have to remember that their ratio has to be maintained, and they should be taken in a powder form, and it has to be in a doses of 2 gram BD. So you have to motivate people to get used to this sort of information. What I do is I spend almost 30 minutes with every PCOS patient on lifestyle modification, and 60% to 70% of my patients come out with positive pregnancy within 6 to 8 months. I'm not flattering. I'm giving it a real practical tips to everyone. But you have to spend time with them because your words are more important to them. The dietitian's words are important. Exercise specialist words are important, but they do come to you for a big help. So if you spend time, give them a good hearing, I'm sure they will hear a lot. And inositol, you can add them when you feel like comfortable of adding this, because this is not a drug at all. I hope I'm making my points clear to every one of you.
Thank you, sir. Thank you so much, sir. So the next question is from Dr. Lillis. She wants to know if, in terms of weight reduction, if you change from sugar to low-calorie sweetener, is there any particular advantage, sir?
No, the sweeteners in all forms are detrimental. So I think if you cannot take a foodstuff without sweet, even a sweetener is not recommended because they have side effects altogether. This is what we have to stress to them repeatedly. People today think that I'm taking brown sugar, but even brown sugars are also not recommended because the calorie content of every one of these are the same. What we are trying to look into it, we have to cut down on the total calorie reduction.
Definitely, sir. Definitely. Any more questions, doctors, to sir?
I think today what I'd like to speak is every smartphone has an application of health application. If you can download it for every one of them, the patients today also have a smartphone in front of us. If you can help them to download the app and at least show them at the end of your visit, maybe after 10 days or even a month, so how much exercise they have contributed in the interval period, they will also get motivated, and we will also get documentary proof who are the patients who need medications for bringing down their weight in addition to lifestyle management.
Thank you, sir. I think that's a very apt comment. I think that makes a lot of information as well, sir. Sir, lots of compliments. I'll read out some to you, sir. One from Dr. Shanti. She tells, sir, excellent presentation. The presentation was from a very different angle.
Thanks to everyone, because it should be beneficial, I'm sure. If it is not, then I'll try to modify somewhere later. But information that I'm trying to give is a little different from everyone, because seminars on PCOS have been quite a few during this lockdown period. But what I have been trying to do is give them an information which doesn't cost them a lot, because we begin from an area where money matters a lot to every patient. So we are finding a protocol which is suitable for our group of patients and finding it very reasonable, a very good alternative to the standard dietary regime. And yes, it pays off. It pays off. Thank you so much.
Thank you so much, sir. Sir, on behalf of Shield Healthcare, first I would like to thank you. Because sir, normally even I attended so many talks of PCOS. They all cover either the pathogenesis or the infertility or the drugs. But you spoke from a very, very different and very practical angle, especially that fertility program was very, very, I think, useful for the audience today. And thank you so much for sparing your time and giving this lecture, sir, on behalf of the. And I would like to thank the audience for participating as well today evening, sir. Thank you so much, sir.
Thank you. Thank you so much. Thank you so much.